So I think since the topics have already been given, so probably the content won't matter as much as presentation style, and I think ease of understanding and conceptual clarity. I think those should be the three if we all decide. So as a teacher, you check in the preview, not on stage. That's one. So all you're checking. If you're not ready, we'll call the next one. Right? Okay. The next one come in. You please check your slides there. Come back in. Are you done?
Yes.
Yes. Please start. So
Good morning, class. So I would like to begin the class with a case. We have a 34-year-old female with these findings, and a diagnosis of primary open-angle glaucoma is made. What would your treatment of choice be? Okay, hold on to that answer. Now, what if I say the same female was pregnant with a gestational period of 6 weeks? Would your treatment of choice still be the same? So let's see if it can be the same. This brings us to the class today, glaucoma in pregnancy. I will be covering these topics. So aqueous humor dynamics includes aqueous production and aqueous outflow. Aqueous production occurs in the pars plicata of the ciliary body and involves three processes: ultrafiltration across the capillaries, active secretion across the non-pigment epithelium with the help of carbonic anhydrase, sodium-potassium ATPase, and passive secretion of the water molecules across, forming the aqueous humor. Now the aqueous humor that is formed goes through the posterior chamber to the anterior chamber via the pupil and can follow two pathways, that is the conventional pathway and the uveoscleral pathway. So what exactly happens in pregnancy? So actually we have a reduction in IOP, and this is because of the interplay of these hormones at the level of production and also at the level of outflow. So at the level of production, pregnancy being a state of metabolic acidosis, there is inherent inhibition of the enzyme carbonic anhydrase, which reduces the production. At the level of outflow, pregnancy being a state of the reduced peripheral vascular resistance, it acts at the level of episcleral venous pressure too, reducing intraocular pressure. Apart from this, we also have the enzyme relaxin, the pregnancy hormone, which causes extracellular matrix remodeling at the level of the Schlemm's canal and the trabecular meshwork, which increases the outflow, thus reducing the intraocular pressure. So despite the normal physiological reduction in the intraocular pressure, if we have a raised intraocular pressure, what do? We reduce the IOP and also ensure the infant safety. So these are the treatment modalities that are available. So FDA has classified the drugs based on the safety profile in the pregnancy as category A to X, X being lethal. The safest drug is brimonidine, and the remaining anti-glaucoma medication belong to class C. So in the first 2 trimesters, we prescribed brimonidine and we switched to brinzolamide in the 3rd trimester. Punctal occlusion is advised to reduce the systemic absorption. Laser treatment is preferred in all the trimesters being safe. And these are the treatment modalities in laser that we have. Surgical treatment, if the disease is progressive and IOP is not controlled, we have to go ahead with the surgery, where we have to ensure different complications at various levels, right from the anesthesia, where there is exacerbation of the hypotension, hypercapnia, which is physiologically present, along with intraop, increased bleeding, surgical positioning, which exacerbates the hypotension, and also pre-op and post-op medications, which are teratogenic. So the timing of surgery is in 2nd trimester. MIGS is the most commonly preferred drug. So commonly preferred surgical modality. So summarizing it, we have 2 classes of pregnant women that can walk into us. One which is already diagnosed, which requires preconceptional counseling and planning to reduce the dependency on the medication, and a newly diagnosed pregnant woman, wherein first 2 trimester we give brimonidine, 3rd trimester we give brinzolamide, laser treatment is given throughout the pregnancy, and surgical treatment is preferred in the 2nd trimester. So I hope the question and the answer to the question is cleared by the end of this class. Thank you.
Thank you, Dr. Rachna. Just one clarity. What was the topic given to you?
Glaucoma in pregnancy.
Yeah, so I think for everybody, just announce this was what was given to me, because it wasn't clear to us even till the end that what was the topic, right? Okay. Ma'am?
Yeah. So that was a nice presentation.
Thank you, ma'am.
So is there any preference to medication and laser trabecular, the laser treatment? When would you
prefer
give you have said laser would be preferable throughout pregnancy.
So, ma'am, if a pregnant woman comes, like in already diagnosed pregnant woman comes to us, then we can give it preconceptionally so that the dependency on the medication will reduce. So we can instead of switching the medications and adding on to medications, we can switch to the laser treatment prior to the pregnancy planning and then continue with the
Will you
medication.
be following up the any other parameters which would guide you whether you can continue the medication or whether you would switch to some other mode of management?
Visual fields and OCT and the intraocular pressure routine monitoring every trimester based on the IOP measures will be preferable, ma'am.
Yes.
This type of glaucoma is suspected in case of pregnancy.
Sorry, sir.
This type of glaucoma is suspected.
In glaucoma, usually it's open angle glaucoma.
Most of the pregnant ladies within the 30 years of age or 35 years.
Okay. Angle closure glaucoma can be because of most commonly open angle glaucoma, but there is a slight incidence of angle closure glaucoma as well.
Would you like to qualify?
Sorry.
Like Dr. Saab said, they'll be less than 30 years old. Would you call it POAG? A technical error.
Would you? Sorry, ma'am.
What would be the definition of POAG? Sorry, you have a teacher
Oh, less
on the
than
other side. So
less than 30.
he said, no?
Okay.
Pregnant woman would be less than 30, early 30s at the most.
Yes, ma'am.
So technically,
Technically, it's not
POAG is
less.
more than 40.
More than 40.
So what would she have?
Just the
JOAG, right?
gestation of life.
Right, okay. Ria, you're next. Come. Please announce your topic. Yeah, the two of them. Timer set kariye, please. 4 minutes.
Can you set it here?
You set the timer, please.
Morning, everyone. So when things get blurry, surgically readjust your focus.
Let's start with your topic, please. We have no idea what.
Yes, ma'am, coming. Good morning, everyone. When things get blurry, readjust your focus. Why not surgically, right? Look at me. I'm a high myope with a -11 dioptosphere. I don't need these glasses, but my minimum corneal thickness is less than 500 micron. Can you suggest me any cases, any surgery for me? Come on, it's simple, right? Lens-based refractive procedure. And that, my dear friends, is my topic today. In lens-based refractive procedure, we have phakic IOL, refractive lens exchange, and bioptics. Phakic intraocular lens, it's a supplementary lens that is inserted to the anterior or posterior chamber of the eye to correct the refractive error. They are available in 3 forms, but due to unacceptable complication, only posterior chamber phakic IOL is used these days. The posterior chamber phakic IOL is inserted to the sulcus, giving an excellent cosmesis and protection to the endothelium. We do not touch the crystalline lens, hence the accommodation is preserved here. We can advise the phakic IOL in cases where LASIK is contraindicated, but he should be at least 21 years with no refractive, no other ocular pathologies and a stable refraction. How to do the workup? A detailed history and a thorough ocular examination, including the gonioscopy, has to be done. In this pentacam, we get AC depth, which should be at least 2.8 millimeters, and a specular microscopy will give you the endothelial cell density. Determining the size of the phakic IOL is also of paramount importance. Now, this is a video of a toric phakic IOL which is being implanted here. A markerless system is used here and the incision is taken along the steeper axis. Once the AC is formed with viscoelastic, the IOL which is loaded into the cartridge is being injected. If you look carefully, you can see some central holes present in this IOL, which eliminates the need of a PI. Once the edges are tucked in, the visco is aspirated, the surgery is over. Simple, right? Post-operatively, what you'll do? You have to check the IOP and the vault. It should neither be a high vault nor a low vault. Now, what if the patient that comes to you already has a shallow AC or has presbyopia or a lenticular opacity? You can advise him refractive lens exchange. It is a removal of crystalline lens and replacing it with another IOL. yes, the accommodation will be lost. So what will you do? You don't have to be worried because we have all these EDOF lenses, bifocals, trifocals, and based on the patient's requirements, expectation, ocular parameters, we can advise the following. Now, a last sentence about bioptics. It's just a combination of a keratorefractive procedure with a lens-based refractive procedure. So whatever the surgery is, my dear friends, everything has got its pros and cons. It is us surgeon, based on the patient's requirements, expectation, ocular pathology, we have to customize each cases. Thank you so much. Yes, sir.
If the patient comes with some posterior segment pathology and there is a harsh root there,
Yes, sir.
ma'am, what should we do?
So first we have to treat the posterior segment pathology because this itself can lead to retinal detachment. So first we have to refer it to the retina specialist. They'll do if it can be replaced by laser, and then we can do the laser. And if there is a retinal detachment, then we'll go ahead with the surgery. If a laser is done, then after 1 or 2 weeks, we'll call up the patient. If we think it's stable, then we can go ahead with the surgery, sir.
I would like to know
Macular pathology?
We will not do, sir.
what would be the difference between ACD and AQD?
AC depth. In AC depth, we don't consider the thickness of the cornea from the endothelial surface to the depth we are measuring,
That's
sir.
AQD. That's not ACD.
Oh, that's it. Okay, thanks.
You said the ACD cutoff for you would be 2.8. Is
Yes.
that right? Or the AQD should be 2.8.
It should be the acute.
It should be the AQD.
Yes.
Right? And what's your cutoff for the endothelial cell count and the hexagonal cell percentage for a phakic IOL?
It should be 2000. Some say it is 2200, but then 2000 is also we can consider.
And what's the most important thing you should check post-operatively, and how much should be the measurement?
It's the wall, sir. So we measure the corneal thickness, and an ideal shape wall should be at least half corneal thickness to 1.5 corneal thickness. So if it is if it's an oversized phakic IOL which we have selected, then it will be high wall. So it pushes everything front. Then the AC, the peripheral AC will be shallow, and it can cause to glaucoma, sir. And
I'm asking how much should the vault be for you to know that it's a perfect fit and it will not rotate and will not cause anything in the future?
it's 250 to 750. We compare it with the corneal thickness, half corneal thickness to 1.5 corneal thickness of the patient.
What's the corneal thickness got to do with it? How much should be the measurement? You're right. You said 250. 250 is actually too low, but yeah, 250. It should be around 500.
500 is a normal, yes.
Who was your mentor?
My mentor was Dr. Deepthi Joshi.
Good job.
Thank you, sir. Thank you.
Nice presentation.
Shall I start? Okay. So today I feel very privileged to stand amongst this august gathering and my learned judges. Today I shall be discussing about congenital cranial disinnervation disorders. Squint has always been a matter of intrigue among ophthalmologists since time immemorial. There was an entity which had sporadic, congenital, non-progressive element to it. People thought, what could that be? They thought maybe that's primarily a pathology of the muscle, and they termed it congenital fibrosis syndrome. This is a 9-gaze CP of a patient I'm sharing with you, where we can see in primary gaze there is a left exodeviation, and on attempted dextroversion in this patient we can see that there is an upshoot. Well, such patients were there, but people could not make a clear understanding of what was the underlying pathology. Later, scientists thought, as I told you, it was originally termed as a primary pathology of the muscle and called as a congenital fibrosis syndrome because the pathological process was thought to be a fibrosis of the muscle itself. Later, doing the autopsy of such patients and doing the imaging of such patients, as you can see in this case, the abducens nerve can be seen on the left side, but you cannot appreciate it on the right side. So, an absence of the abducens nerve in a case of squint, well, clinicians again started to think, what was there which they were missing? They again sat together and realized the pathological process which was earlier thought to be primarily in eye muscles was actually a primary neuropathic and a secondary myopathic process. And thus came the birth of congenital cranial disinnervation disorders. In 2002, there sat a congress which decided that from now on, all these disorders with a primary neuropathic and a secondary myopathic process would be termed and clubbed under congenital cranial disinnervation disorders. This is a classification of the same. Because of paucity of time, I shall be running through it. There can be primarily vertical disorders like congenital fibrosis of extraocular muscles or ptosis, congenital ptosis, advanced retraction syndrome, Okihiro syndrome, congenital facial palsy, and Mobius syndrome. A schematic diagram. In part B, you can realize the oculomotor nerve is present proximally but not distally. In part C, which is a case of DRS, you can see that the LR is not supplied by the 6th cranial nerve and has a misinnervation from the 3rd cranial nerve. They can occur at the level of microtubules, at the level of gene transcription or receptor signaling, as has been seen in CFUM and DRS. A DRS patient can have a problem during the adduction, which can cause a narrowing of the palpebral aperture, and during abduction, it can cause widening of the palpebral aperture. They can be divided into type 1, 2, and 3. And the management primarily involves aligning the eyes in primary position and reducing the upshoot and downshoot. A Y-splitting procedure was devised by Jampolsky in 1980 to reduce such cases where there can be a sudden upshoot, because a wide split would give a broad base for the insertion of the muscle. If they are associated with radial ray defects, as you can see here, or you can remember your pharmacology classes where there was phocomelia during thalidomide toxicity, they can be called as Okihiro syndrome. A CFUM patient generally presents with ptotic eyelids, infraducted globes, difficulty in supraduction, and chin up position. A congenital ptosis patient, and a Mobius syndrome where there is a facial palsy along with the limited abduction of the affected eye. So my dear friends, I am glad that you could give me your patient time and listening. I would feel very humbled and grateful if you could understand the basic pathology which led to the development of CCDDs, that it is primarily a neuropathic and secondarily a myopathic process, which was done by years of research, autopsy examination, and imaging of these patients. Thank you and namaskaram.
Thank you. So, why does a co-contraction, what do you mean by co-contraction in some of these cases?
Ma'am, if I take a case of advanced retraction syndrome, when there is a limited abduction or there is a congenital absence of a 6th cranial nerve, there is a misinnervation by the inferior division of the 3rd cranial nerve. Now, that 3rd cranial nerve, when the patient tries to do an adduction in that eye, there is a firing of the medial rectus, but the medial rectus simultaneously also fires the lateral rectus. Because of this simultaneous firing, both the nerves contract and try to pull the globe. And this leads to a reduction in the palpebral aperture during the adduction.
I'd just like to correct you somewhere. It's not Mobius, it's actually a Mobius syndrome. That's how it's pronounced.
Thank you so much, sir. Thank you so much.
Mobius syndrome.
Thank you so much.
And the other thing is, say a patient has come to you with a congenital fibrosis syndrome and severe ptosis and a huge chin-up head posture and wants to get rid of that chin-up head posture. What treatment would you offer to that patient?
So we would like to give a primary ptosis correction surgery first, so that the child...
Which ptosis correction surgery?
Sling surgery would be good in such patients, sir.
What would be the material that you would like to use for the sling?
A frontalis sling can be used, or artificial materials can also be used.
Okay. And how much would you correct?
Sir, supramaximal correction. How much would you correct? We would like to do a supramaximal correction in such cases.
In congenital fibrosis syndrome, there would be no Bell's phenomenon.
We are not going to correct the muscle, but we will try.
Whatever you do, if you do supramaximal without any Bell's phenomenon, there will be severe corneal xerosis.
Yes, sir.
So you just clear the visual axis and leave it there.
Right, sir.
Would you touch the recti if a congenital fibrosis syndrome also comes with a squint?
Sir, if there is a difficulty in abduction, as has been seen in certain cases, we can even do a correction of the recession. We can do a MR recession also in such cases.
You will not resect any muscle?
So resection would be a double whammy in such cases, because that can even lead to further tightening of the globe and difficulty later on.
Good.
Thank you so much. Thank you.
Morning everyone, I'm Dr. Diksha and I have been given a very dry topic, corneal cross-linking, but I'll try to add some spice to it. So let's see how we begin. So this is my outline. So to begin with, what is cross-linking? Of course, creation of bonds. Which bonds? The strongest bonds that we know from chemistry are of course the covalent and the ionic bonds, and hence these bonds. between two polymers, and hence we connect the two polymers and we create a new material that has altered physiochemical properties. So this is a chemistry. If all of you are really interested, I can begin this. But those who hated chemistry in their school are free to take a short Instagram break, right? So this is the molecule of riboflavin, and this is something called delocalized electrons. Now, can I have the coordinates, please? These delocalized electrons can be photoactivated by UVA light to an excited triplet state of riboflavin, and this triplet state then interacts with the excited riboflavin then interacts with the substrate in aerobic and anaerobic reaction to bring about the product. And this process has been used in polymer chemistry and has been used to manufacture various prosthetics. So that is okay, it makes sense, but why would someone think of cross-linking cornea? So let's see the anatomy of cornea. And a cornea consists of regularly arranged lamellae of collagen, which provide biomechanical strength to a cornea. And there is a disease where this regular arrangement is altered. The disease is called keratoconus, in which there is thinning without collagenolisis. So these bonds are broken and the cornea loses its biomechanical strength, and there is progression of keratoconus. And hence, obviously, cross-linking will help. And this idea first arose in the city of Dresden in Germany in 1997, you cannot see it because of the timer, by Professor Eberhard Sperl, who thought of cross-linking the corneal buttons of a pig. He used various mechanisms, and a significant improvement in stress-strain index was seen. You can see here the stiffer cross-linked cornea. And 10 years later, human studies were done with something called Dresden protocol, which I'll come to later, and a significant reduction in progression of keratoconus was seen. More studies, and CXL achieved FDA approval in 2016. So brief slide about the technique. This is the cornea. First, the epithelium is removed. We inject riboflavin. The photosensitizer is now in the place. What next do we need? Of course, light, UVA light, which will create the cross links, and the process ends with placement of PCL. Now, this is the photochemical reaction which is governed by this law. This law of Bunsen-Roscoe law of photochemical reciprocity, which says that if your total energy is constant, you can have the same photochemical reaction irrespective of the irradiance and the time. And the total energy set by the Dresden study was 5.4 joules per centimeter square. Now you can achieve this 5.4 by different mechanisms, 3 by 30 or 45 by 2, but not more than 45, because Wernley has reported that if irradiance is more than 45, the efficacy markedly decreases. Now the first one, where 3 milliwatt for 30 minutes, was the original Dresden protocol, the conventional CXL. It had excellent efficacy, but longer duration was the limitation. So we have this something called accelerated CXL, and similar results have been reported, and maximum efficacy is with 9 into 10 and 18 into 5. This is the most commonly used protocols of accelerated protocols. So these are the complications which I would skip because of paucity of time. We'll discuss this in the next class. And I would give a home task. First is to revise, and next is to read about the prerequisite for CXL, especially a pachymetric cutoff, which is very specific and there's a reason behind it. So please read about it. We'll discuss that in the next class along with other topics. Thank you.
What is the wavelength of
365 nanometers, sir. Actually, many wavelengths were studied. Maximum efficacy was with the sunlight in the original study. But again, that was not practical. So next was this 365 nanometer. Oh, I cannot show it here.
damage to lens and retina?
So that is a question for next class. Definitely, if I can tell that if the irradiance is more and if the cornea is thinner, the UV light can penetrate deeper, cause iritis, lens damage, endothelial damage. So the cutoff is 0.018 milliwatt minute per second. So if the cornea is thinner, you can have endothelial damage, and hence that is a prerequisite for CXL. Instill, sir, I showed the video.
Yes.
No, it penetrates.
You said then we inject.
Oh, sorry, that was my mistake. That was my mistake.
Okay, just one technical thing for the judges to note. This was supposed to be a PG program. So Prafulla, I had no idea whether a senior resident would be eligible, because it is for junior residents who have not passed. It says that postgraduates, right? It is. So So we'll have to keep that in mind. Please make a note, judges, that she's not a postgraduate, she's a senior resident already.
Both of them.
Both.
Yours also is, sir.
Yeah, that's why I put this up, that Delhi has to take note of the fact that we are making a note that these were senior residents, they've passed, they're ophthalmologists already. Right, anyway.
But there would be something, sorry ma'am, there would be something that I would like to speak which would probably cheer you up before you climb down the days. This was a proper class feeling. I loved it.
Thank you, sir. Thank you so much.
Vaishya, is she there? All right. So on to you, Dr. Bilal.
So good morning everyone. My name is Dr. Bilal Pathan. I will be presenting my seminar on lower lid eye reconstruction surgeries. Anatomy. Eyelid is a bilaminar complex structure, protects the globe, maintains the integrity of the tear film, divided into 3 parts: anterior layer skin, muscle, middle septum fat, and posterior conjunctiva and tarsus. Anatomy mainly consists of septum, capsulopalpebral ligament, and septal spaces. Skin thinnest measuring up to 0.3 mm, and there is no scarring. Orbicularis oculi muscle divided into preseptal, pretarsal, and orbital part. Orbital septum separates the eyelid from deep structures, and it acts as a barrier to prevent the infection, hemorrhage, and inflammation. Tarsal plates, these are connective tissue which supports the eyelid. Now we start with wound construction. It's like restore and replace, like with like, and the construction depends on anatomical integrity, physiological functioning, and osmosis and blending. So the main thing is while constructing, at least one must have its own blood supply. Technique would depend on the size, location, and configuration, depth of defect. Superficial defect, only anterior lamella needs to be repaired, and full thickness defect, it needs the construction of both layers. Principle: 3 components are must: outer layer of skin, inner layer of mucosa, and the semi-rigid skeleton. Periocular zones 1, 2, 3, 4, and 5. We are mainly dealing with zone 2, 3, and 4. Zone 2 lower lid, zone 3 medial canthus, and zone 4 lateral canthus. Stepwise approach. First we classify the defects: anatomical, congenital, coloboma, facial defect, epicanthal fold, and anatomical defects which are acquired, trauma, burn, and carcinomas. Functional defect: congenital, ectropion, telecanthus, and acquired ectropion, entropion, and telecanthus. Biomechanical defects: aging, exophthalmos, injuries, medical diseases, palsies, etc. Timing of the repairing: if cornea is exposed in a congenital defect, repair within first week; cornea not exposed, delay for a year. Traumatic repairs: primary within 24 hours, delayed primary repair 3 to 4 days, secondary for 6 months. Small defects: direct closure, primary pentagonal dog ear; direct closure with lateral cantholysis, in which we directly detach the lower limb and angles incision superiorly. Moderate size defects: tensile flap is used. Advantages: reconstruction of anterior lamellar defects. Disadvantage: no lash restoration. Second, huge flap. In this, we do a vertical upper lid and lower lid sharing. And advantages: reconstruction of large defects, composite flap. Mustarde flap, it is a good flap for very large defect, and it's a single stage procedure. Calhoun's composite eyelid graft, we take a graft from anywhere and just we stick it in the lower lid. Large defects: mustarde, cheek skin is used. Freecase flap, we use the skin from the temporal side. Median forehead flap, nasolabial, we use the flap from the forehead. Split finger flap, reconstruction of medial canthus for zone 3 and lateral canthus region for zone 4. Blepharoplasty, in which we do the tightening of the lower skin and remove the excess fat. Transconjunctival blepharoplasty, in which the fat pockets are removed from the inside of the eyelid. Most important thing is the pre-aponeurotic post-orbicular space and orbicular muscle should be preserved. Carcinoma surgeries divided into frozen and Mohs surgery. The reconstruction depends on the type and defect or the size of the eyelid removed, and then they are reconstructed with the flaps which I have mentioned. Direct closure complication: notching, wound dehiscence, tension. Graft complications: scar, graft, eyelid sharing flap complication, malposition. Most common complication is chemosis, epiphora, ectropion, retraction, ptosis. Take home message: 30% of the lid can be closed primarily. Lateral canthotomy or cantholysis can also close the primary, can allow the primary closure of large defect. Skin only defect can frequently be reconstructed with contralateral eyelid skin. And tarsal for graft is used. Prevention of tension, proper anchoring, critical anchoring. Thank you. Let's pass.
Thank you. So When you take a free graft for the anterior and posterior lamella, what do you have to keep in mind?
First, the first thing is the size of the defect and the anatomical plane from where you are taking, and the second thing is the blood supply of the graft.
So can you take a free graft for the skin, anterior lamella as well as the posterior lamella?
No, we can take only for anterior lamella because it's the easier and there are more vessels, but for posterior lamella it's very difficult for a free graft because there are no proper supply.
Which year are you in?
Second year.
The second year postgraduate.
Second year postgraduate.
Okay. So, I mean, this is just again another comment, and
Yes,
since
sir.
this podia, these platforms have been given to all of you, because the AIOS wants people to be groomed, you know, and one of the primordial things that you should understand, all of you should understand, if you want to become a reasonable orator in the future, is to have a stage presence. And the stage presence comes from the fact that you have to understand your audience. Herein, you are actually essentially addressing the class, your students. And as a teacher, you should have that body language which speaks of confidence. You had everything in the slides, tremendous content. But probably, you know, the authority, that gravity, the dearth in your voice should have been a little more pronounced than it was, is what I feel.
The class is for 40 minutes.
Yes,
You have
sir.
to keep us attentive for 40 minutes.
40 minutes.
You know, what I meant was, please understand and kindly take it in a constructive manner. There is a difference between explaining things and reading out what is written on the vision. There is a difference. That's what I hope the hint would make you understand what I'm trying to say.
Thank you.
Good luck.
Thanks.
Next is Dr.
Good morning, all of you. My topic is minimally invasive orbital surgery. 20 to 30 years back, we never could have imagined that today we will talk about minimally invasive orbital surgeries. Minimally access surgery has gained popularity in many fields of ophthalmology. The orbit is an anatomically complex region that is affected by heterogeneous pathologies. Therefore, we need a collective knowledge of and skills of neurosurgeons and ENT surgeons and ophthalmologists. The overriding principle in orbital surgery is to preserve vision, and to achieve this, we have to choose the most appropriate surgical approach to avoid manipulation of optic nerve and its vascular supply. Pathologies in lateral aspect of orbit is accessed via external approaches including lateral orbitotomy and frontotemporal craniotomy. Pathologies involving medial aspect of orbit is accessed via anterior medial microorbitotomy, and lesions close to orbital apex is accessed via endoscopic endonasal approach. This is the clockwise model showing the access to the orbit for various approaches from 12 to 12 o'clock. This is the surgical entry sites in orbit. Like A shows the classic stellar right lateral orbitotomy. B shows the eyelid crease lateral orbitotomy approach. We will discuss in short about medial orbitotomy approach, which includes transconjunctival, transpalpebral and transcaruncular approach. In transconjunctival approach, we will approach the axis we will approach to orbit via 1 to 6 o'clock in the orbit, and this is suitable for the tumors located adjacent to globe surface and excellent for evacuation and drainage of mucoceles. In transcaruncular approach, dissection begins between caruncle and plica semilunaris. In transpalpebral approach, it offers a minimally invasive alternative to frontotemporal craniotomy. The main advantage of this approach is the avoidance of coronal skin flaps and good access to orbital roof. Indications includes inferior and medial lesions, Tenon's capsule pathology and cavernomas. Endoscopic endonasal approach is to facilitate dealing with orbital fractures and lesions behind the globe in the inferomedial orbit. These approaches are included in endoscopic endonasal approach. Its advantages are good cosmetic result, not very invasive and fast recovery, but disadvantages includes it requires familiarity with endoscopy. Lateral orbitotomy includes eyelid crease and lateral canthotomy. It is very less invasive than transcranial approach and offers the option of adding an osteotomy. This is the picture showing the lateral orbitotomy in which the orbitus axis from 8 to 10 o'clock and then eyelid crease and lateral canthotomy is done. In this approach, superior eyelid crease, it is useful for the management of pathologies of frontal sinus and posterior wall fractures. In precaruncular approach, it is indicated in cases involving cavernous carotid artery and medial aspect of cavernous sinus and optic nerves. A short note about minimally invasive surgery for intraconal orbital surgery. Tumors were classified on the basis of its relationship with optic nerve in 5 groups. These are the 5 groups in which they were classified. And endonasal approach was done in type 1 and type 2 lesions. Most common diagnosis was cavernous hemangioma. Conclusion: the minimally invasive operating technique leads to less pain, faster recovery, quicker return to work, and better cosmetic results. Thank you.
The judges would like to. Any comment? Any comment about the presentation?
No, whatever Anurag has said previously, no. You may have it more than 10-15 minutes for it. You have got the opportunity to make use of it. Don't get scared. When you are teaching us, you are the most informed person.
Okay, sir. Thank you.
So if I could just comment upon the slides. No, it's 10, 20, 30 usually. 10 slides, 20 points, and not more than 30 point size for your font size. Because there's no point in putting in lots and lots of sentences on a slide, because they could just go back home and read that, isn't it? You have to distill all that you want to say in points. This is this, and the rest has to be same. So the one thing that is, learn to talk to your audience rather than read from your slide, because they can see what is written. So it's easy to make a presentation, believe me. But all the presentations that you see and you think are nice, believe me, those people have worked very hard. And I can tell you, it takes me about 6 to 8 hours to make an 8-minute presentation, and I'm not joking. Because while making it, you'll think, acha, there was that guy, and then you search for them, and then you want follow-ups, and then you want something. It looks easy. The easiest thing to do is to copy and paste abstracts, copy and paste text, copy and paste pictures. But it defines a good teacher from an everyday teacher when you know what you have to say. You're saying all that you have presented on the slide, but you're not putting it on the slide at all. Right? So that's one thing that I think, more than content, we are looking at people who can get across the idea that you want to present here. Yeah?
Every word out of that for all of you was a pearl, because that came right from a top-notch operator in the country. Honestly.
Yes.
Thank you.
Next, and Deepika, I believe, will be ready. Tell us your topic, Samir, and who you are. Introduce yourself.
I'll be presenting on cataract surgery in 2030. I'm a third-year resident from Arvind Eye Hospital, Madurai. More than our past and present, we often think how the future is going to look like. A very good morning to one and all. Today, we'll be trying to answer the question of how cataract surgery is going to turn out in our near future. So what can we expect in the upcoming decade? Let's see as we discuss the surgical technique, the intraocular lenses, the reversal of cataract, and the changing trends. With advances in the surgical technique and high patient expectations, cataract surgery is evolving rapidly to become a refractive surgery. This demands high surgical precision, and existing technologies such as the femtosecond laser assisted cataract surgery, the Optiwave refractive analyzer, and image guided systems such as Varion and Callisto are going to play an important role in achieving the same. More recently, robotic surgical systems are being explored in the field of ophthalmology, which includes cataract surgery as well. Two such systems with high precision and stabilization are Iris and Precise, which have shown excellent results in the preliminary studies. Coming to intraocular lenses, which have been constantly evolving ever since the invention, also promise an exciting future. To begin with, presbyopic IOLs attempt to overcome the disadvantages of a multifocal IOL as a group. In the current era of smartphones and smart TVs, it was inevitable to not have a smart IOL. They are made up of thermoplastic acrylic material which completely fills the capsular bag and retains the accommodative behavior. Accu focuses a small aperture in the center, which gives it a pinhole effect and increases the depth of focus. In accommodating IOLs, two types have shown encouraging results, the dual optic IOL and the fluid vision IOL. But the type that excites us the most is the perfect lens, where a low-grade femtosecond laser can be used for the post-operative adjustment of the IOL power and design, and this makes it especially exciting for a pediatric ophthalmologist as the IOL can be adjusted for ocular growth. Additionally, multifocality can also be added, and in case the patient doesn't tolerate it, it can be reversed, just like an eraser for a surgeon. Next up are the light adjustable IOLs, which are made up of photosensitive silicon macromer, allowing the use of UV light for post-operative adjustment. Telescopic IOLs, this is a Lipschitz macular implant which has two mirrors in the center, magnifying the central rays by a factor of 2.5, making them especially useful for macular pathologies such as ARMD. IOLs are also being explored in the field of biosensing technologies and have been tried for the monitoring of intraocular glucose and IOP. Drug-eluting IOLs are the one where certain drugs are attached to the surface of the IOL and then slowly released inside the eye. Various antibiotics such as moxifloxacin has been tried for the prophylaxis of endophthalmitis, and various drugs with anti-proliferative properties have shown to prevent the formation of PCO. Coming to the part which has the potential of making all of us jobless, reversal of cataract. 3 compounds have shown encouraging results. The first one, N-acetylcarnosin, which has antioxidant properties and has shown improvement of visual acuity and reduction of glare. Sterols such as lanosterol and 25-hydroxycholesterol decrease the aggregation of crystallines in vitro, ex vivo, and animal models. Rosmarinic acid is a naturally occurring polyphenol with antioxidative properties which remodels the protein aggregates. And since we are in this beautiful land of coconuts, we found something very, very interesting. A study has shown that coconut water protects the lens from diabetic cataract in animal models. Such a simple thing can cause prevention of cataract. As we all know, cataract is the most common cause of preventable blindness, and as India transits from a low-income to a middle-income country, improved accessibility to eye care is expected, which will in turn improve the quality of life and decrease the dependency. A recent survey has shown that only 14% of ophthalmologists are exposed to phacoemulsification during their residency. This is concerning considering what the future demands. In conclusion, the future is very exciting and promising in the field of cataract surgery, something we should all look forward to. The future is not something we enter, the future is something we create. Thank you.
Interesting, yes. So once the cataract has occurred, is there some way you can form the lens without introducing an IOL?
So smart IOL, ma'am, is a type of, it is made up of thermoplastic acrylic material. So we...
What is LAL? Is it still in light adjustable?
Sorry, ma'am?
Light adjustable IOLs?
So light adjustable IOLs are made up of photosensitive silicon macromer, ma'am. So for the post-operatively, suppose we want to fine-tune the lens, suppose there was a refractive surprise or so what we can do, we can expose the lens to a localized UV light of wavelength 365 nanometer, and once we get the desired lens, we lock in the lens by exposing the entire IOL to the UV light.
Have they been found successful now?
It is being used, ma'am, in several practices, ma'am.
How long you have to drink coconut water? How much? Because it's so expensive. If I drink coconut water for 1 year now, I can get 2 eyes off it. So economically, surgery is better than coconut water.
When was the study published? You sure? About the coconut water? Is it recent one?
Yes, ma'am. I think in the last 5 years it was published.
Okay.
Any other comment? Thank you, Samir.
Thank you.
Can we have Deepika on?
Can we start now? Good morning, everyone. Today, let us have an overview of my topic, surgically induced necrotizing scleritis. Before starting my class, let me ask you a question. Slides. Can I just reset, ma'am? It's stuck. Can you just start the timer, please? Good morning, everyone. Today, let us have an overview of my topic, surgically induced necrotizing scleritis. Before starting our class, I would like to ask you a question. Did you know that excess use of cautery in your surgery can end up like this after months to years? Scary, right? Everyone knows sclera for its strength, but today we'll see that it can also melt. Inflammation of sclera, scleritis, is a painful vision-threatening condition which can be either predominantly infectious etiology or of autoimmune etiology. In scleritis classification, surgically induced necrotizing scleritis is classified under anterior scleritis necrotizing type with inflammation. It is a rare complication happening after various ocular procedures, months to years after the surgery, with a mean interval of 9 months, where there is scleral ulceration, thinning, and uveal exposure, that is scleral necrosis at your surgical site. Here you can see porcelain white avascular sclera in the interpalpebral region adjacent to your limbus post-pterygium excision. It can be either perilimbal, superior or inferior quadrant, as here you can see multiple bunch of grape-like lesions of scleral thinning and uveal exposure following cyclodestructive procedures. More posterior lesions can be seen following glaucoma valve implantation or scleral buckling surgery. So what is causing this necrosis? There are various mechanisms involved in the pathogenesis, like any surgical trauma to your sclera, any tight mechanical compression due to a scleral buckle, excess use of cautery, infection, use of metabolites or radiation. But today we are going to speak in detail regarding our main culprit, that is your autoimmunity. 63% of the patients have an underlying autoimmune disease, most commonly rheumatoid arthritis and granulomatosis with polyangiitis. So in these patients, any surgical trauma will cause the antigens to get exposed and altered. And there is immune complex formation. And there is deposition of these immune complexes at the episcleral vessels in your surgical site, leading to scleral inflammation, destruction, and melting. So how do you diagnose this condition? The first and foremost important thing is your history. Any past history of ocular procedure done previously and a thorough medical history to rule out underlying autoimmune rheumatological disorders is really important. Then comes your clinical examination. It is really important that you differentiate an infectious etiology from an autoimmune etiology, because your entire line of management is going to differ. We suspect an infection in the presence of purulent, mucopurulent discharge, presence of any scleral abscess at the surgical incision site, or other anterior chamber findings like hypopyon, which are not typical of your autoimmune etiology. Then we investigate the patient. In case of infectious etiology, swab for your smear and scrapings for your culture, and tissue biopsy can be done to find out your offending agent. In case of non-infectious etiology, your blood investigations and imaging are done to rule out the underlying autoimmune rheumatological disorders. So in the presence of infection, the patient is started on broad-spectrum antibiotics and antifungals, which can be adjusted according to your culture sensitivity reports. In case of autoimmune etiology, your main goal of management is to suppress the inflammation and to halt the progression. So your first line of management is steroids. Oral steroids can be started. In case of a rapid progressive disease, IV steroids. In case of non-responsiveness, immunosuppressors. And if there is failure with all these agents, biological agents can be started. In spite of adequate medical management, if still the disease is progressing or if there is an impending perforation, surgical management such as conjunctival resection, conjugal Tenon's flap, or a tectonic graft must be done in order to preserve the globe architecture. So we've almost come to the end of our lecture, and I would like you to take these 5 points home. Surgically induced necrotizing scleritis is a rare complication happening after various ocular procedures, believed to happen due to an underlying autoimmune mechanism. And before initiating the treatment, it is really important you rule out any infectious etiology and you detect it early and hit it hard with steroids and immunosuppressors so as to prevent any ongoing autoimmune destruction and secondary complications like scleral melting and staphyloma. Thank you.
Thank you. It was a Nice presentation,
Thank you,
well
ma'am.
conveyed.
Thank-
So, how often do you see this?
It's actually very rare these days, ma'am.
For shorter time, I think we'll go ahead because we started off late too. Thank you.
Thank you, ma'am.
Dr. Deepika, isn't it?
Right. So I think Telangana is next.
Before I begin, my name is Anirudh Herur. I'm a second year resident at LV Prasad, Hyderabad. Yeah. Yeah. So each and every one of these cinematic personalities that you see on the screen have received their fair share of discrimination simply because of how they look. A similar fate awaits these individuals who walk into our OPD unless we as doctors, as ophthalmologists, offer timely help. So today I'm going to take you all through a journey of 3 different stories of 3 different patients managed in 3 different ways, but all of whom suffered from one condition: Blepharophimosis ptosis epicanthus inversus syndrome, which is my topic of the day. So our first story is that of Amar. Amar was a 6-month-old child brought to the OPD by his distressed parents because he was the only one in the family who had these ocular features. They were well educated and wanted to know more about the disease and the management options. So BPES, I told them, was caused by a genetic mutation in the FOXL2 gene, which is nestled within chromosome 3. It is primarily expressed in the developing eyelids and the ovary, and hence the delineation into 2 types. Type 1, which affects primarily the eyelids and the ovary, and type 2, which affects only the eyelids. It is relatively rare with an incidence of 1 in 50,000 and has an autosomal dominant inheritance. Now, why we think that Amar has this syndrome is because of 4 cardinal features. 1, Blepharophimosis, so blepharo lid, phimosis shortening, so a narrowing of the horizontal palpebral fissure. Ptosis, which is a drooping of the upper eyelid. Epicanthus inversus, an abnormal skin fold over the medial canthus going from the lower lid to the upper lid, hence inversus. And lastly, telecanthus, which is a widening of the intercanthal distance. Now, the parents asked me, what is the solution at this stage, doctor? And the solution was simple. At this stage, we simply observe. Imagine yourself to be Amar. You're a 6-month-old child and your functional visual field is restricted to the toys on the floor or playing with your parents. Hence, even a moderate ptosis isn't really going to hamper your functional vision. However, as Amar grows up, we need to keep a lookout for amblyopia because of severe ptosis, because of strabismus and refractive error, both of which are associated with BPES. And also, if they're planning to have a second child, it is better to get a genetic evaluation done because they could be harboring the mutation. Now, our second story is that of Akbar, an 8-year-old child with a very strong family history. Both his father and his grandfather had the syndrome. So the parents weren't really concerned about cosmesis. What they were concerned about, though, that Amar had a chin up or a chin elevation posture and couldn't see the board very clearly even with his spectacles on. He was constantly being bullied at school for this, and he did have a best corrected visual acuity of 20 by 40 in both eyes. So in this case, we went ahead with ptosis correction using a tarsofrontalis sling. Now remember, the parents weren't really concerned about cosmesis, so we can defer a canthoplasty for correction of the other cardinal features for a later stage. However, this child does require alternate eye patching for amblyopia management. Our last story is that of Anjali. Anjali is a 25-year-old female who was looking to get married but was facing a lot of rejection because of her features and came to us seeking cosmetic correction. She also had menstrual complaints which were suggestive of a secondary amenorrhea. So in her case, we went ahead with the 2-stage surgery. The first surgery was a YV medial canthoplasty for correcting her telecanthus and epicanthus, and the second surgery was a ptosis correction which was done 1 year later, and this was the final outcome. Now that she was looking to get married and possibly conceiving, we also sent her to a gynecologist for infertility management and a genetic counselor for future risk in progeny. Now, as I went through the literature, I had a lot of interesting questions, a couple of which I've jotted down on the slide above. I would like all of you to go through them and get back to me with the answers either by the end of the session or by the end of the day. And lastly, the teachers of tomorrow are incomplete without thanking the teachers of today. Thank you.
scan and you will not correct her?
No, so the primary thing about correction in BPES is there are two indications. One, as we saw in Akbar, which was amblyopia, and two, which we saw in Anjali, which was cosmesis. So if she as an individual does not want cosmetic correction, it is not warranted. If she is confident in her own stride without it, then it's not required.
No, the cosmesis and marriage are not related. That's what I mean.
Yeah, it was just her complaints that what she was facing as an individual, she was getting rejected because of this. Hence the reason.
What would you do for the telecanthus, which was there? What was done?
So for the telecanthus, so usually what is done is along with the correction of a YV medial canthoplasty, a lateral canthoplasty is also done. But in this case, it was not required.
What would you do for telecanthus?
So for telecanthus correction, we would do a YV medial canthoplasty. So medial canthoplasty would essentially correct both the telecanthus and the epicanthus inversus.
What do you mean by telecanthus?
Telecanthus is a widened intercanthal distance between the two medial canthi. So essentially the interpupillary distance is normal, but the intercanthal distance is the same.
Any other questions from the judges? Anybody? Any comment?
Thank you.
अब शुरू होने जा रहा है देश का सबसे बड़ा मुकदमा, आपकी अदालत।
So namaskar everyone, welcome to Aapki Adalat, and today we have a very special guest with us. जब भी लोगों के आंखों के सामने अंधकार आ जाता है या कोई उनकी आंखों में धूल झोंक देता है या फिर आंख में दर्द पीड़ा ऐसा कुछ होता है, तब ये इनको याद करते हैं एंड इनके पास आपकी सारी प्रॉब्लम्स का, आंखों की प्रॉब्लम्स का मोस्टली हल है. बट आजकल ये काफ़ी चर्चा में रहे हैं अपने कामों के कारण. तो प्लीज़ स्वागत करिए डॉक्टर शर्मा का एंड जजेस एंड जूरी का, जो हमें आज के मुकदमे में हेल्प करेंगे टू कम टू अ कंक्लूजन. सो डॉक्टर शर्मा, आप पे पहला इल्ज़ाम ये है कि आपके पास एक पेशेंट आया था जो जिसकी अपने दोस्तों के साथ लड़ाई हो गई थी और उसी मारपीट में उनको आंख में लग गया था. अब उनको उस आंख से दिख नहीं रहा, तभी आपने कोई मेडिको-लीगल केस फाइल नहीं किया था. सो डॉक्टर शर्मा, वकील साहब, जो आप बोल रहे हैं वो सही है, लेकिन मैंने फाइल में ये भी लिखा था कि ये एक एलिजिड हिस्ट्री है एंड पेशेंट ने खुद ने मना किया था मेडिको-लीगल केस करने के लिए, विच इज़ क्लियरली डॉक्यूमेंटेड in my findings and in my reports that the patient has refused the MLC. The court had called me in the same regard, and whenever I had received the summon, within 3 days of it, I had given all my documents to the court and I had attended it in the person, and I have an attendance certificate from them saying them. Now, why is it important? Because any kind of eye injury comes under grievous hurt, and there are very serious criminal punishments for it. So any kind of eye injury, whether domestic or workplace injury, should always have MLC done.
Can you just pause the timer for a second? Timer thoda pause kar denge. We still don't know halfway through what are you talking about.
It's the medico-legal aspects in ophthalmology.
So that's the first thing, because your class is halfway through and they're still at sea. Bolna kya chahte hain? Now we know, right? So always introduce that. Today we will be discussing so and so. Today we will talk about so and so, right? Okay.
So the learning point from this case would be that whenever the patient is not willing for MLC, actually you should do MLC for all kind of ocular injury, but if the patient is not willing, you should mention it specifically, and all your electronic records or all your data should be maintained for a minimum of 5 years and ideal situation for 10 years. So डॉक्टर शर्मा, आप पे दूसरा इल्ज़ाम ये है कि आपने एक पेशेंट को जो कैटरैक्ट से पीड़ित था उनको जो आपके एडवर्टाइजमेंट पढ़ के आया था और आपने उनको बताया था कि सर्जरी के बाद उनको ग्लासेस नहीं लगेगा, अगर मल्टीफोकल लेंस डाल दिया बहुत अच्छे से दिखेगा. एंड ड्यूरिंग द सर्जरी ही ऑल्सो हर्ड यू शाउट एंड स्क्रीम एट द सिस्टर्स फॉर समथिंग, and now the patient is unhappy that he has to wear glasses for the same. So how do you defend yourself in such a situation? ऐसा नहीं है वकील साहब, मैंने तो वो पेशेंट को बोला था कि कभी कभी थोड़ा गलती हो सकता है, थोड़ा बहुत ऊपर नीचे नंबर कैलकुलेशंस में हो सकता है, बट ज़्यादातर केसेस में ऐसा नहीं होगा और चश्मा मोटा मोटा निकल जाएगा. But sir, how do you justify that screaming and shouting in your OR which he heard? Because आपको लग रहा था कि वो सो रहा है, but आपके most of the patients कभी नहीं सोते, उनके कान खुले रहते हैं and they are aware of what is going on in the OR. Also, you should not claim things that you cannot achieve. Like अगर आप बोल रहे हो कि चश्मा नहीं, you can never say the patient that चश्मा नहीं लगेगा. You should always counsel them properly from what is the diagnosis, what is the plan, how you are going to manage, what are the complications which are associated, and how you will manage the complications as well. So a honest and complete communication is very important. So why all this is important? Because our topic was medico-legal aspects in ophthalmology, and these are the acts which are related and pertaining to ophthalmology, and these lay the ground rules for how a doctor should behave and what are the punishments if anything goes against or crosses it. As we all know, a doctor is liable, a doctor has both criminal and civil liability in the court of law. And according to claim statistics, they have said that 73% of the alleged cases of medical negligence in ophthalmology were proved and were given compensation up to 1 crore. And in those cases, this indemnity insurance comes in help, which insures the organization or a private individual, wherein if they are stuck with a criminal or a civil negligence. So सावधान रहे, सतर्क रहे. आपका कौन सा पेशेंट आपके करियर के लिए घातक हो सकता है, you never know. Be very vigilant. And the court is adjourned for the day, and I would like you to scan that barcode for the reading material which is necessary for the same. And all the reading material related to medico-legal case is in that drive link which you can refer to. I hope you all never require it. Thank you so much.
Thank you. Do you need the consent of the patient to record your medico-legal records to write down the injury medical report? I mean injury report.
Actually, in cases of injury, it is whether the patient wants it or not, but it is better for
everyone.
But it is better for us, because if we are called in the court of law as a witness, we should have something that will save us, and that is our priority at that time. So if you have not documented anything, it is going to go against you.
I thought I heard you say if the patient is willing, you have to record.
You have to record whether the patient is willing or not, everything.
Yeah, I have 2 suggestions for you. Most of the time you are looking at the board talking. Maybe I think eye contact to her.
She was the lawyer as well as the advocate as well as the.
Actually, the thing is, if I.
I'm just saying.
Sorry.
Give us the eye contact, number 1.
Yeah.
And number 2, you are from some medical college. Let me explain. What is the medium of instruction in that college?
So we give instructions to our patients in English.
Because as a person who doesn't know much of Hindi, half the class I was Hindi.
Okay.
And you assume that everybody knows Hindi in your class. So we understand, because figurate, there are so many languages, but English is the medium.
Yes.
You have to take into that also.
Okay.
Shall I start? Good morning, everyone. Today we are going to talk about the evaluation and management of the non-diabetic 6th nerve palsy. We have no financial interest in this presentation. As we all know, there's a lot of the work done on this topic. So first we start with the anatomical consideration. We must remember that the nucleus of the 6th nerve lies in the lower part of the pons along with the nucleus of the 7th nerve, and emerges from the lower part of the pons and goes through the posterior cranial fossa. Towards the petrous part of the temporal bone. It passes under the Gruber's ligament in the doloris canal. Then it injected into the cavernous sinus and goes through the supraorbital fissure and then supplies the ipsilateral lateral rectus muscle. Now coming to the etiology, it can be divided into congenital such as the developmental neuronal migration defects, hydrocephalus and cerebral palsy, as well as the acquired which consists of the intracranial tumors, trauma, elevated intracranial pressure, or meningitis. The etiology can be also divided into localizing causes such as the pontine lesions and the suprapontine lesions like acoustic neuroma, and non-localizing causes such as the microangiopathies and the intracranial hypertension. Now, coming to the clinical presentation, the classic clinical presentation is a esotopia, which is the worsen for the distant than the near. There is a abduction limitation with the adduction normal. There will be the horizontal binocular diplopia, and there will be abnormal head posture. Now, coming to the evaluation shall be done under the following headings. First, we start with the meticulous history taking. Patient, in the most of the cases, patient comes with the chief complaint of the eye deviation and the double vision. And in the children's prenatal and prenatal and birth history, along with the developmental history of utmost importance. In the adult, the history of the diabetes, hypertension, and the trauma are very important. And then we move on to the general examination, in which we look for the abnormal head posture, facial asymmetry for the association of the seventh nerve, ptosis, lid retraction, and the hearing loss. Now, coming to the evaluation, in the evaluation, there will be the abnormal head posture. We must recall the visual acuity and do the cover test to see the amount of the primary and the secondary deviation. Then we move on to the Worth 4 DOS test, which is done with the diplopia goggles, with the red glass in the front of the right eye and the green glass in the front of the left eye, in which the patient with the normal retinal correspondence with the squint in the right eye sees the 5 lights. Then we evaluate with the Maddox dot, and then we document the extraocular movements. In this case, we can see that in the dextro version, there is the abduction limitation. Then we chart then we do the Hess chart for the total for the amount of the muscle. Then we do the Hess chart for the documentation of the muscle movements. To aid in the surgical intervention, we do the force reduction test and force injection test. After that, we move on the predetermine the battery of the investigation. For the most of the neurological cases, MRI is a gold standard, and it should be considered if the age of the patient is less than 45 years and it is associated with the pain or neurological abnormalities, or if there is a idiopathic bilateral acute onset bilateral sixth nerve palsy. Now, coming to the treatment. In the most of the cases, it is common that it will resolve spontaneously, like in the unilateral isolated and non-traumatic sixth nerve palsy. The spontaneous recovery occurs more commonly in the unilateral than in the bilateral cases. We can also do the patching, which can be the binasal occlusion or full monoocular occlusion. We can also give the patient the central prisms, which are the base out prisms, and in some cases, botulinum toxin can effectively used. We can we can also do the establishment surgery in the long-standing cases, in which we do the Jensen's procedure, Hamelsing procedures, and Nishida procedures. Thank you.
Okay, that was a rushing. In 4 minutes, you have covered a lot. So, sixth nerve palsy. When would you give Botox?
Yes, ma'am.
Botox.
Ma'am, if there is a small movement, and in the early cases, ma'am, when the contracture is not settled in.
Acute cases.
Yes,
acute. So you have talked about patients below 45 years.
Yes, ma'am.
So above that, what would you do? No MRI.
No, ma'am. We can do the MRI. Ma'am, if it is an acute onset with the neurological deficit, then we must go for MRI, ma'am.
Okay. Thank you.
Thank you, ma'am.
Last one, Dr.
A very good morning, everyone. So I think everyone present in this hall have your smartphones, laptops, iPad with them. We all have them. So we have no financial interest. Let me start with a basic question. The first thing we do in the morning when we wake up is checking our phones. I think majority of us do. And the last things when we go to bed, we scroll the social media sites, and then it's a habit nowadays scrolling the sites. So is the social media same as the social networking? The terms look like same, but social media function as a communication channel that delivers a message which involves asking for something. And social networking is a two-way, a direct communication that involves sharing of information between the several parties. We have various medias, we have platforms in social medias like the collaborative projects, content communities, social networking sites, blogs and community platform, and disinform. Now, social media is already having so much impact on life, and there are various published articles in the renowned journals showing the impact of the social media in the ophthalmology and the eye care. So, how the social media rising so much? In the current era, majority of the people are familiar with the mobile phone and its applications. Online shopping, food delivery, car booking, everything is in our hands. And now it has seen that the social media and the healthcare apps basically have evolved with the estimation of 1.8 billion by 2024. So now how it's ruling the eye care. Social media is changing the nature and the speed of the eye care among the general public, the patient and the professional due to increase in the communication and the interaction with the STEAM organization dealing with the eye care issues. It has the potential to increase the interaction and thus are provided with more valuable, shared and tailored information. And it has a wide access to those people which are not usually access to the traditional modes of eye care. Now, who are our target audience? It's always about the audience. We have the patients suffering from the eye problems, the general public, and the postgraduates and professionals in the ophthalmology. What is the objective of social media and ophthalmology? To diagnose, educate, and research in the field of eye care, to raise the awareness and disseminate the information and integrate the ophthalmic health and to communicate with patients. Now, it's a blessing to the residents. We have various online sources which we can go ahead with just a click and get a lot of information. It helps in the diagnostic and research. Gone are the days we have to sit in the library and search for our thesis material and everything. We have e-learning apps, and now apps are making our life so easy. So why we lag behind in learning? And now the online webinars, they are just so comfortable. But we can access them and sitting at home in our time. But we do miss the free lunches in the seminar. Do we miss all? And in the COVID era, it comes out as a new guardian angel. In the COVID era, everything when we shut down, it reduced the gap between the eye care professionals and the patients. And I think everyone know it was an ophthalmologist who first posted about the signs and symptoms of COVID on the social media site. So, and it also helps in increasing the surgical skills of the resident by the various programs we have. And do not let your vision fade away. Protect it every day by spreading the awareness. You should know the glow so that they live and see. We have various online programs where awareness posters seen which can help in knowing these lethal childhood medicines so that they can be treated at the right time. Even we have an app for the retinoblastoma, or we can say basically the white reflex patients, so we can diagnose. It helps in fighting the silent thieves of the sight by spreading the awareness. So it's also a symbol of hope for those who are waiting. We have various eye donation online apps and the links which we can access through. And there's a new thing which is coming up. There's a teleophthalmology. We have various programs going in India like SNTOP, ANT and KidDrop. But everything that glitters is not gold. Social media helps us, but there are quality concerns and the lack of reliability. The authors of websites are often unidentifiable and there are numerous. But the physical examination was and will always be a gold standard. To conclude, it's a dimension to a new care, but a robust research is required to establish the authenticity of its contents, and it's a powerful tool for us. It's my acknowledgements. Always keep your eyes on the stars, but your feet on the ground. Thank you so much.
Nidhi, are there any downsides?
Yes, ma'am.
Your presentation was all about all that glitters, but is it really? It's always nice to have a limitation or a downside.
Yes, ma'am. It's because, ma'am, the sources we have, we don't know from where it's coming. We don't have any authorized. The authors are usually sometimes are not there, and like the wrong messages are all spread through the social media sites.
Also, the excess of social media and screen time on the.
Yeah, ma'am. That has a screen.
That has to come.
Yes, ma'am.
You spoke a lot about social media and ophthalmology. You never spoke a word about how the election campaigning happened in social media.
Thank you. Hello, Dr. Nidhi. One just last word. Yes. While presentation, your eye contact was not present. So take care of that next time. Wish you the best. Thanks so much.
Thank you.